I'm Ramesh Bulusu, one of the oncologists in Cambridge. I'm the network lead for GIST in East Anglia and also run the National Clinic for the pediatric adolescent wild-type syndromic GIST. I've got a bad habit of not able to stand still, so it might be a bit of a challenge for the cameraman. I don't like standing still. I keep running all the time. So there are two presentations today. One is an issue for all of us in the GIST world. We know that Gleevec was the original imatinib going back to 2002, I think it was, when it was approved by FDA. And initially it was approved for a condition called chronic myeloid leukemia, which is a blood cancer. And that changed the outlook of the cancer completely. Prior to that, we were using chemotherapy for patients with chronic myeloid leukemia. And the moment they found out that imatinib works, it changed completely. The whole thing, the whole algorithm, whole paradigm shifted dramatically towards just using a tablet. And we were about 2 years behind chronic myeloid leukemia research. And again, by chance, imatinib was discovered that it could inhibit a protein called KIT, which is one of the enzymes which is mutated in lots of GIST patients' tumors. So that was the kind of background. And Novartis came along, and they had this compound in their hand. They had it for a number of years, didn't know what to do with it. And suddenly it became a valuable molecule for CML and the GIST patients. So Gleevec was the commercial name. It was licensed and approved for use, and NICE approved back in 2004, I think it was. We started using it. Those days we were happy that we had a tablet because prior to that we were using chemotherapy with quite serious side effects for the patients. So we didn't really do much about how to use the drug. It's one tablet once a day, just take it, happy, side effects, tough it out, that kind of thing. But luckily, imatinib majority of the patients had manageable side effects. A few patients had significant, sometimes serious side effects, but majority of the patients had manageable side effects, meaning in the beginning of the treatment, in the first few weeks, maybe first few months, a bit of a tiredness, nausea, dry skin, skin rash, puffy eyes, watery eyes, cramps, very common, but they settle down kind of thing. But some patients can have more medium to longer term side effects as well. We have not seen any serious life-threatening side effects in a big chunk of patients, but we have seen few side effects, including liver toxicity, inflammation of the lung called pneumonitis, and severe depletion of phosphate levels in the blood, and that can be quite serious as well. But these are rare side effects. This generic imatinib is something which we want to share our experience with. So Gleevec, which is the patented product by Novartis, the patent runs for X number of years, usually about 15, 20 years, and then patent runs out. That means other companies are allowed to make the same drug, and they often tend to be cheaper. So this happens with all the drugs, not just cancer drugs. Every single drug you think about, there's a patent, and the patent runs for X number of years, and then the other companies, when the patent runs out, other companies start making. Next, please. This is the journey a drug goes through, and the journey is, it starts around here. We don't know anything about these things because these are actually what we call preclinical, just about there, and this can be anything up to 4 to 10 years before the drug actually comes into use in human beings. And this is where lots of money is spent. And if you imagine going back to, say, 20, 30 years ago, only about 5% of the drugs which actually were tested would actually come into the market for the company to make money. So 95% of drugs actually fall by the wayside in what we call as the early phase trials, phase 1, phase 2, perhaps, and that's it. Even sometimes they go up to phase 3, and then the trial is negative, the company won't go for a license. It happened with a couple of the GIST drugs as well. And then the patent runs for 2 years, and then the products become available for patients in general use, and then the other companies can come and take over and start making the drug as a generic drug. This is identical. What we know is that when you make a generic drug, when a company makes a generic drug, the composition, the molecule, the active ingredient is exactly the same. Then what changes, what is different is sometimes formulation is different, meaning what they add to the drug to make it stable is probably different. And sometimes the coating is different, sometimes the size is different, sometimes the shape is different. And this again happens with practically all the drugs. And the reason why we switch from a patented drug to a generic drug is because the generic drugs are cheaper. I give an example, which is a very common example. Imagine you got a bit of headache and you got a muscle pain, that kind of thing. You take Nurofen, but it's also available as ibuprofen. Nurofen is the patented drug. Ibuprofen is the generic drug. Go to Tesco Sainsbury's, buy ibuprofen, costs about 60p, 80p, maybe £1. Go and buy Nurofen, it costs about £3-4. Same drug, same ibuprofen. The formulation, the actual active compound is exactly the same, but the formulation is a bit different. Some people swear by Nurofen, say it works for me, ibuprofen doesn't work. It doesn't get rid of my headache like that. And some people say ibuprofen gets a lot of side effects, but Nurofen doesn't, but it's in the same drug. So that's a very good example to think about what is the difference between a patented compound and a generic compound. The reason why we switch is because it's cost savings. So generally, if you think about cancer drugs, the generics are possibly at 2/3 less or even 3/4 less than the patented drug. So they are much, much cheaper. That means you will be able to give more and just save money. Next, please. So this is what we said. The reason why I went back to these slides is we gave a talk to GIST Cancer UK in March 2022 in Bath. Myself and one of the pharmacists from Royal Marsden. And what we sold at the time, I distinctly remember that you don't have to worry about anything. Generic Imatinib is as good as Gleevec. That's what we said. I distinctly remember summary slide, don't worry. Okay, I wanted to come back this year because we've done some more work in Cambridge, working out what is the difference between Gleevec and generic Imatinib. So we know that in principle, in theory, generics should be safe as the patented one, should be same efficacy and same high quality. And this is the bottom line. Sometimes they look different, size, shape. People are worried about that. So this is what we have now. This was the original Novartis compound called Gleevec, which is what we were used to, the color of the tablet and everything. Then we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 companies which are making Imatinib. Imatinib is the active ingredient of all these things. And some of these companies, we probably know them, Sandoz, for example. Others we are unfamiliar with this one, this one, this one, this one. This one is relatively new. This one is vaguely familiar. And these two are again, this one we have worked with them before with other drugs. Next, please. So what I'm going to tell you in the next 10-15 minutes is what has happened in Cambridge since 2021. So we've been using 3 drugs and we settled on 2. This is the Teva. Teva is a French company, is one of the leading companies making generic drugs in oncology. So they got a really long track record. And this is a relatively new one, company called Addenbrookes. We haven't used this one. There were some supply issues with the company, so we actually haven't used it. So we use either Teva or Addenbrookes. Next, please. That's what it looks like. Addenbrookes Imatinib is tiny, small white pill. And Tiva one looks very similar to Gleevec. So you say, well, this is very similar, means it's the same, but this one is supposed to be the same as this one and this one. Next, please. So we presented the paper, a poster in a British Sarcoma Group meeting a couple of weeks ago in Newport. And Jenny Harrington, he's one of the medical oncologists who led the project. So the aim was to try and work out the patients who have switched from Gleevec to a generic compound, or patients have started on a generic imatinib, and see what happened to them. So we looked at why they were having the imatinib, and also what sort of side effects they had, how long they have been on the imatinib, and also the outcome, what actually happened to the patient while they're on the tablets. Another thing what we have introduced in Cambridge is we now very routinely measure the imatinib plasma levels, that means blood levels. It's become a standard of care in Cambridge, not as yet in the rest of the country. We're hoping that we can engage with the other oncologists and try and make it a standard one. We were talking to the Dutch team, and it's standard in Holland. So what does it mean? You take a tablet of imatinib, 400 milligrams, and it takes a while for the body to build up the levels inside the tissues, inside the tumor, and also in the plasma. So you wait for some time, and then you take a blood sample, and you send it off to the laboratory, and you measure the blood levels. And there has been work done in chronic myeloid leukemia patients and also in GIST patients, telling us what should be the adequate level. Not necessarily the level which is going to work, but what is supposed to be adequate for getting a response. So we got that data from a number of years ago. So this is what we did. Next, please. So 50 patients, expected age range. 8 patients were having treatment before the operation, what we call as neoadjuvant imatinib, with a view to downsize the tumor, make the operation much more safer, much less morbid. 8 patients were having adjuvant, meaning they had the operation already done. They were deemed to be at higher risk, so they were having treatment for 3 years. But majority of the patients were having treatment because they already had disease which has gone to other parts of the body, and they were on the imatinib to try and control the disease, hopefully get a response, and keep them stable for as long as we can. These numbers are a bit high in Cambridge. Again, my practice is different to the rest of the country. We tend to use more neoadjuvant imatinib, meaning we give imatinib prior to the patient having an operation, especially for stomach GIST patients. The reason for that is in gastric GIST or stomach GIST patients, sometimes the tumor is very close to some of the valves, either junction between the esophagus and the stomach or between the stomach and the duodenum. Sometimes a bit too big, and the surgeon says, I might have to take the whole stomach out. We said, don't. Give the imatinib first, shrink it, and hopefully do a more conservative, what we call as a sleeve or wedge resection. And we have been very proactive in implementing that in Cambridge. I'm not sure what the practice is other parts of the country. It would be a very worthwhile project to look at this. We talked to the Association of Upper GI Surgeons. It's called AUGIS, because big chunk of the GISTs are in the upper GI territory, meaning in the stomach, small bowel. So a snapshot showed that Cambridge has got something like 80%, nearly 100% more number of patients having preoperative imatinib than other centers. But we want to look at this data in much more detail. The reason for this is our surgeons are signed up. They've seen the benefits of imatinib in the preoperative setting where the surgery becomes much easier, smaller tumor, not enough blood in the tumor, doesn't bleed, it's almost scar tissue kind of thing, easy to take it out. And the operative time is much shorter as well. So that is what they tell us. So this is something which is very different to other parts of the country. So lots of patients have been on imatinib for a very, very long time, but the median is about just under 2 years. Next, please. So 28 patients switched from the original Gleevec, which is the Novartis patented compound, to a generic compound. And I deliberately missed out the names of the drugs. In the poster we put generic X and generic Y, or generic Z. We didn't say what they were for various reasons. So they commenced on generic X. 21 patients of the 39 had more than expected toxicity. You can say that, well, this is not a big deal, is it? But for the patient who's taking it, bitter taste for hours and hours is horrible, horrible side effect. And he can't eat, he can't drink. And bloating, abdominal cramps were very common. The interesting bit was some switched from X to Z with improvement in the side effects. Okay, and generally feedback was that Z was better tolerated, less GI side effects. Okay, next please. So this is the side effects point of view. 11 patients, unfortunately, the disease has progressed, meaning the tablets were no longer working. 9 of these 11 patients were on generic X. Okay, then you ask the question, what is happening with this generic X? So we check the plasma trough levels. One of the disadvantages we have is that we haven't been routinely doing plasma levels in this country. We just were, not that we didn't want to do it, it's just we were happy that we had a tablet, it works in majority of the patients, why bother kind of thing. But it's not because of laziness, it's because we were happy with imatinib for years and years and years, yes. So we didn't really go that way, unlike the Dutch guys. So we started checking the plasma levels about 2 years ago. So 18 patients had the levels checked. The level should be 1.1 milligrams or above per liter. That's the kind of a recommended level in patients with GIST when they take imatinib. So that's the recommended level. Subtherapeutic levels, meaning less than 1.1 milligrams per percent, 5 out of 7 patients with generic X with progressive disease, meaning when they had tumor progressed, meaning no longer responding, 5 out of the 7 patients had lower levels of imatinib. And this was checked at the time of progression, meaning when the disease has progressed on the CT scan, when we felt that the imatinib is no longer keeping the disease under control, we checked the plasma levels, and levels were low in 5 out of the 7. 3 patients on generic Z who has progressed, their levels actually were fine, meaning the progression was not due to lower imatinib levels. It was likely to be due to secondary mutations developing in the GIST. 4 patients who had progressive disease on generic X switched to generic Z with confirmed clinical response, and repeat levels checked that levels are actually back to where they should be. This is the important thing for us, not that patients have progressed on generic X or generic Z, that patients who have progressed on generic X, when we switch them from X to Z, the disease, we got the control back. And also we rechecked the levels from being low, they went up. So the message there is that this is not a progression due to acquiring secondary mutations, which is the most common reason why the tablets stop working. But in his case, this is what calls a pharmacological resistance, meaning the tumor was not getting enough imatinib into the tumor cells. That's probably the reason why it progressed. This is a very, very important, serious thing for us in the GIST world. Next, please. This is a pictorial representation. So just CR means complete response, PR is partial response, PD is progressive disease, NED means nothing can be seen. Red is progressive disease on generic X, blue or purple is progressive disease on generic Z. You just have to look at the levels. So this is, focus on the purple blue one first. We said levels should be 1.1 or above. So if you look at the 3 patients who had progressive disease, their levels actually are adequate. See, 1.49, 1.9, 2.16. They're pretty happy, adequate levels of imatinib. But look at the red ones, generic X, 0.43, half of what they should be, 0.78, 0.58. Look at this one, 0.28, a quarter of the level should be. And the patient is taking standard dose of 400 milligrams of the imatinib. So there's a wide variability in the absorption of this drug compared to the generic Z. Next, please. So what we concluded was that we saw more toxicity, more side effects with generic imatinib compared to Gleevec, and most of the toxicity seemed to be confined to generic X, not Z. This is an important message we need to remember. The progression we see sometimes on the CT scan may not be due to secondary mutations, may be more due to the subtherapeutic levels, meaning the levels are actually lower than they should be. Other thing what we learned from Ian Judson's research from a number of years ago, Professor Judson is the doyen of GIST, he's our mentor kind of thing, he's there up there. What he discovered is that over a period of time, the imatinib levels go down anyway. If you've been imatinib for 2-3 years, and if you measure the levels, say in month 1 month on imatinib, and you measure the levels 36 months later, the levels drop. That is because of the way the body handles the drug. So over a period of time, the levels do drop. And that is a well-known fact. It happens with most drugs. But this is something which is beyond what we have seen, in the sense that levels dropping to 0.2, 0.4 is more than what we expected. The problem we have is the data on the equivalence came from most of the studies done in CML, chronic myeloid leukemia. There were very, very few studies done in GIST. And also you have to remember that GIST patients have various operations done on the GI tract. Some patients have the stomach removed, some patients have the small bowel removed, and the availability of the drug because of the operations could have an impact on how much drug is being absorbed as well. So what we felt was that when we presented this in the BSG, British Sarcoma Group meeting a couple of weeks ago in Newport, we said, why don't we actually have a national study, start prospectively, meaning with a plan to do what we want to do in the next 12 months kind of thing, pick up 4 or 5 centers and get a bigger data set. We only got 50 patients. We need maybe 200, 300 patients to actually to get the numbers and see what is happening to these patients. Right now, we are measuring the plasma levels in Cambridge, but we don't do them in-house. They go to King's College in London. They have a pharmacology and toxicology laboratory, which is been there for 20, 30 years. So well established. All the quality assurance, everything has been done. So we felt that it's much easier to send a sample down to King's College from Cambridge. It takes about 7 to 10 working days, probably 2 weeks, for the blood levels to come back. At the moment, they're not charging us. If we want to go bigger thing, they may charge us. But again, the cost of doing a blood level is peanuts compared to what we're seeing progression-wise and everything. So this is something which we want to do. And we've been talking to the other GIST specialists in the country, and everybody is in agreement. And it's a question of writing a project protocol and get them signed up. It is non-interventional in the sense that we're not intervening, we're just measuring things. So it should be easy to get it through ethics. And then hopefully get some data out by the end of the year. Other thing we have not put this in the guidelines because the guidelines are just coming out now. They're in my inbox right now. Ian Judson and I, we've been working for the last few months. I'm very keen on this to be in the guidelines. The question is, do we have enough data to say this should be a standard of care? Personally, I feel that this should be standard of care. I think every patient who has an imatinib need to get their plasma levels checked. We do that in other drugs. For example, if you give antibiotics, you're inpatient, you're in the ITU, get antibiotics, you get levels checked. You go on medications for your epilepsy, you get your levels checked regularly. So there's no reason why we shouldn't be doing this in just with imatinib. That also brings us to the question whether we can do the same thing for other drugs. For example, sunitinib. Pfizer was making sunitinib. It was called Sutent. Now sunitinib has gone off patent. So we got a new sunitinib, which is a generic sunitinib. If the patient is on generic X and they've been doing well and their plasma levels are adequate, we don't have any problems with that. So we have no problems on patients who are generic X or started on generic X. Their side effects are very similar to what we expect. Bit of puffy eyes, watery eyes, bit of cramps, fine. And the plasma levels are fine, we are happy. So we're not forcibly changing patients from one generic to other generic just because we don't like the other one. We know that all generics are the same. For some reason, that one particular generic, the bioavailability, meaning the amount of drug which goes into the system and goes into the tumor, seems to be variable. There's a bit of a hit and miss, and we don't like that. If you take paracetamol, 500 milligrams of paracetamol, and you only get 400 milligrams into your system, fine. But if you're taking an anti-cancer drug and you only get 60% or 50% of the drug into your system, into your tumors, into your cells, that's not acceptable. That's my personal feeling. So this is what's happening with the generic imatinib in Cambridge. With the help of Just Cancer UK, we want to get this as a national project. I think we can work on that one. And writing a protocol is very straightforward because the patients are already on imatinib. Consenting would be very straightforward. And blood sampling, we do blood samples, for example, can do every 3 months, every 6 months for the cohort of patients to make sure that they got adequate levels over a period of time. And I'm hoping to go to Amsterdam, not for a holiday, but to meet up with the Dutch team. We had a telephone, with a video conferencing with them last week, and to see how they do it, so that we can actually hopefully import the same protocol for us. We can use the same one instead of reinventing the wheel, because they've been doing it for a number of years. So that summarizes the generic imatinib, I think. Yep. Questions?
Oh, here we go.
Thank you. You only tested 2 of the generics that you listed up there. Are you going to test the others, or is anybody else? And I have another question. You have differences in blood levels. Now, I'm assuming, although you didn't actually say this, that the nasty one was the one that provided horrible side effects. We as a patient group did a survey of about 6 of those, not all of them, and we found that patients responded very differently to the different generics. And some of the side effects were truly horrible, as you said. Now, if the side effects are horrible, are you absolutely sure that your patients are actually taking the drug every day?
Right. First question. So there are about 7 or 8 generics available in UK. It depends on which hospital you are and which company they are actually procuring from. So we don't know why a particular hospital has chosen a particular company. In the NHS England, the bottom line is the cost, so the cheapest one. In Cambridge, prior to this study, we were using only 2, maybe 3 generics. And the more and more data coming through in the last year or so, we have moved away from changing one generic to another generic. We said if a patient is started on generic, whatever the generic is, stay on that drug, because there may be some inter-generic variability as well. I know up north they're using Sandoz or Accord, one of those things. We don't know what the absorption of those drugs is. We don't know that because they haven't measured the plasma levels. The other question which comes into discussion is, okay, you're measuring the plasma levels. How do they reflect how much imatinib is going into the tumor cell? Do they reflect that bit? That we don't know. In the sense, we are using plasma levels as an indirect surrogate marker for the amount of imatinib going into the tumor cell, the presumption is that plasma levels reflect the amount of imatinib going into the tumor cell. That's the presumption. It may not be 100% correct. Because sometimes you got adequate plasma levels. There are some different ways of developing resistance apart from mutations. The drug may not get into the tumor cell. The tumor cell may have a pump which pumps out the drug from inside to outside. It's called drug efflux pumps. It happens with lots of drugs, not just imatinib. So some drugs which try to get into the tumor cell, they get in, but the tumor cell pumps it out before it does kill the cell. And that means you got adequate plasma levels, but not adequate levels in the tumor cell. So that we don't know. So that's a variable which we can't prove either way. Then the question of compliance. Trust. Ask the patient, this I'm taking, oh God, I'm swear, I'll take it. But we know that when they return the boxes sometimes, it's instead of supplying every 2 months, it's come up to 3 months. So wait a minute, I gave you 2 months supply, but you haven't asked us for another 4 weeks. That means, have you been taking? Oh, I've been taking, but how come there's another 3 weeks in the system, in your pocket? Oh, well, oh yeah, I forgot on Friday, I forgot on Sunday. But majority of the patients say to me, I don't miss it. But if you interrogate them and gently take them to the pub and then say, what did you do? Then they will confess that actually they haven't been taking. But again, this is a big issue in the GIST world. I think we have never been able to honestly answer that question. But if you send out a survey from the GIST cancer care patients, I think I know what the response is going to be. Almost everybody will say, I'm taking it. But we know from our drug supply, because at the moment what is happening with NHS England is that you can only dispense the imatinib for 2 months. 5 years ago, I was able to dispense the Gleevec for 3 months, 4 months, 6 months. They put restrictions on the amount of imatinib which can be dispensed at a given time to maximum 2 months. So now we know that if the patient has not asked us for a refill, because they can only come from your hospital, they can't come from the GP. So they haven't asked for refill. Our presumption is that they probably haven't taken it every day for the last 2 months. Because if they haven't had a refill for 3 months, that means they are without imatinib for a month. Probably not true, but maybe they haven't taken for weekend, Saturday, Sunday, they were going out. So they got extra 8 or 10 tablets left. Then they will phone us 2 weeks before. So that is very difficult.
And the worse the side effects, the greater the non-compliance, I suspect. So if you can find a generic with the fewest possible side effects, you're more likely to get good compliance.
That's correct, yeah. In our experience, the one which is the brown, orangey, long, which mimics the Gleevec, is the one which has got the least side effects. Other thing is a psychological angle to this as well. My patients are very, very worried. Back in 2021, when we said we're switching, they didn't want to switch. I've been on Gleevec for 6 years, 10 years, 3 months, whatever. I don't want to switch. I said we don't have a choice. It is coming from NHS England, so there's a lot of psychological overlay to the symptoms as well. So in the first few weeks, I didn't like the tablet, it was horrible, horrible. Then they got settled down. But they've been the guys who've been on the imatinib for a number of months or number of years. So once that they're okay with that, side effects got better. So that's another thing which we need to remember, that sometimes the first few weeks, the side effects potentially could be because of the anxiety levels building up with the switch from what they trusted the tablet as Gleevec to something unknown for them because the generics are unknown quantity for them, for the patients. So that is another issue which we haven't been able to address in our patient cohort. The hard facts are that not all generics are the same. That's the first thing. Second is there is some degree of variability in the bioavailability of the drug, meaning the amount of drug which goes into the system. And this varies from generic to generic. And one particular generic stands out, And that seems to be the one which we are avoiding in Cambridge. Across the nation, if you want to do a big study, I think we need maybe 250, 300, that kind of a number, which we should be able to generate within a year. And that gives you nice, good, hardcore evidence to see what's actually happening when you are on generic imatinib. And also it gives a message to the NHS England that, it's not the cost of the drug per tablet or per pack. Actually, what happens to the patient is more important than counting the beans. What surprised me is that in the NHS England, when they made the decisions about switching from Gleevec to generic, nobody consulted the oncologist. And on the committee, there's no oncologist on the committee. And he asked the question, why? I mean, because this is a commercial decision, it's a procurement decision, and they felt that we've been doing this with all the other cancer drugs. Same. But we know in our world, because I also treat lung cancer, and lung cancer we use the same NIBs, imatinib type of drugs. Again, there's a specific mutation in one of the genes in some of the lung cancers, so we use a tablet to treat the lung cancer, and tablet works very well. We have the same anxieties, but luckily in lung cancer we're about 15 years behind GIST, so the patent won't run out for another 10, 15 years, or even 10, 15 years. So we have less anxiety in lung cancer. But we do know that there's a variability in the absorption within the patient from time to time, depending on what medication, other medications they're on. Other thing which we haven't properly interrogated is what other medications is a patient on while they're taking imatinib. Because we know in your small booklet you get, there are certain drugs that can make the imatinib levels go up, certain drugs make the imatinib levels go down, and we have recorded the data, we got the data, but we haven't analyzed it. So that again is an important variable. If you're going to design a study, we need to get that, what we call as concomitant medications, CONMEDs. So what other medications patients are taking? For example, statins. A lot of patients are on statins. A lot of patients are on a drug called omeprazole or lansoprazole. So these have impact on the way the imatinib is absorbed. So we need to look into those things as well.
In relation to generic X, so in order for, it's obviously licensed, so is it just doctor prescribing power that will reduce the number of patients going on to generic X before you've got your big cohort? Because obviously it's out there and it's available, and there must be lots of patients who are on it who may well be at risk of suboptimal levels.
So good question again. What we need to do is we need to provide hardcore data for NHS England, bigger than study. We've only got 50 patients, which is not enough, out of which only 38 patients were on generic X. If we can get another, say, 100, 150 patients, not necessarily generic X, but all generics, and if one or two generics stand out that they're subtherapeutic levels, doesn't matter what the level is, then we can go back to NHS England and say, by the by, we don't want you to buy. Yeah, I agree. I think we need that bigger number.